let me start by introducing myself. My name is Jorge Ugas. I am a senior technical advisor on health economics for the Palladium Group and also for the Health Policy Plus project. It is my absolute pleasure to be moderating this session. Its title is "The Gap Between Polyfinancial Management Best Practices and On-the-Ground Exigencies Closing, Evidence from 3 African Countries." We are going to be learning from experiences from our colleagues in the countries of Nigeria, Malawi, and Kenya regarding PFM. Let me say just a couple of words about our presenters. We have the privilege to have here with us today Sunita Sharma. She is the Vice President for Health for the Palladium Group and also the Director of the Health Policy Plus project. She will be providing some overarching thoughts about PFM, about the things that we have learned in the recent past on PFM in a few countries, and she'll be mainly setting up the stage for our next 3 presenters. In terms of the key presenters or the speakers that we have for today, we have first Francis Ilika. She is HP Plus Country Director for Nigeria, and her presentation will be focusing on how they, in Nigeria, through HP Plus project, they overcame some polyfinancial management obstacles to mobilize resources for HIV in the country. Second, we will have my colleague Atamandike Chingwanda. He is our HP Plus expert on health financing in Malawi, and he will share with us some experiences on how PFM affected the delivery of healthcare services, focusing on the case of the Malawi healthcare system. And then finally, we have David Kaoya. He's the Deputy Country Director for HP Plus Kenya, and he will be talking about how in his program they were able to counties were in Kenya were able to achieve pretty important budgetary gains for health through some shifting of the PFM paradigm. We estimate that the presentations will take overall between 35 and 40 minutes, and we hope to have 20 minutes for Q&A at the end. As you can see, there is a chat box at the bottom of your screen. I encourage all the presenters to actually drop any questions whenever they feel like they want to ask any questions to the presenters. I have asked the presenters to please, wait until the end of the 3 presentations for the Q&A. So hopefully they will be able to answer all the questions at the end, and we're actually looking forward for a productive and engaging discussion. I also want to let know all the folks, all the attendees here, that you can use the meeting app in case you want to watch pre-recorded presentations, in case you want to have access to the abstracts or the slides, if you want to connect with the presenters. It is actually very user-friendly. A couple of reminders. The first one is that the session is being recorded. You can turn off the live transcript. You can click hide subtitles in the live transcript button. I think that by default it's set up as being on all the time, but you can easily turn that off. And finally, to let the presenters and also all attendees here remind them that the session is going to be available 1 week following the end of the Congress. It's going to be available on the Congress platform. You should be able to access not just this presentation in this session, but all the sessions from the conference, and they're going to be available for 1 year. So without further ado, I pass the mic on to Sunita Sharma. Sunita.
Thank you, Jorge. So we all know that meaningful progress towards universal health coverage requires countries to ensure sustainable and sufficient domestic public financing for the health sector. The increased emphasis on sustainable domestic financing in the achievement of UHC has amplified the vital and fundamental nexus between PFM and health financing. While increasing revenue and domestic public resources for health sector is key, countries must also make efficient use of available resources in the health sector through better alignment between budget planning and health sector priorities, and ensure that health resources are allocated and targeted more efficiently, and budgets are executed and managed as planned and in full. This requires improved financial management policies and practices that reprioritize government budget in a way that increases government allocation for health within existing resource envelope so that more is obtained out of existing spending. This understanding has made PFM an integral part of enabling progress towards UHC. PFM is key in optimizing not just how public funds for health are raised, but also how they are allocated, managed, and accounted for throughout the PFM system. HP Plus project has been engaged in PFM reforms in several countries. We have seen increased resources for health and essential services, including family planning, maternal health, and HIV. Our PFM health work has focused on equipping ministries of health to effectively engage in constructive budgetary dialogue and coordination with ministries of finance and treasury to optimize fiscal space for health sector. Increasing resource envelope through efficiency gains, sensitizing ministries of health on the importance of PFM in health sector planning and budgeting, including alignment of budget allocation with sector priorities. Strategic and equitable allocation of resources, efficient execution of budget, and accountable and transparent budget monitoring. Advancing equity and efficiency in allocation of resources at different levels. Improving budget absorption rates at both national and subnational levels through improved release and flow of funds and procurement reforms, providing reliable and timely information for Parliament, CSOs, and citizens for increased accountability and transparency. So how PFM in health reform pan out in practice, especially at local levels, is extremely important in informing our understanding of what works and what does not work in a given context. So I'm so excited. I really look forward to hearing from my colleagues from Nigeria, Malawi, and Kenya, what something has worked for their countries and some of the challenges they faced and also the achievements they have. Thank you, Jorge.
Wonderful. Thank you very much, Sunita, for those words. And now my colleague Francis Elika. Francis, if you are there, you are looking forward to hear about your experience on overcoming PFM obstacles and mobilizing resources for HIV in Nigeria. Francis?
Thank you very much, Jorge, for the introduction. Can you hear me well now?
Yes, I can. Yes, we can.
Okay. Yes. Can you see my slide?
Yep.
Thank you. And thanks to Sunita for that excellent introduction. So thank you to everyone that joined this session. I'll be sharing our lessons from Nigeria on using public financial management to actually influence additional resources, domestic resources for HIV/AIDS programming in Nigeria. So this session or this presentation I'm going to make is particularly interesting because it goes beyond generating evidence through our public financial management analysis to actually taking this evidence to influence the action of key actors in the health sector and in the HIV sector and even outside the health sector, which actually led to some desirable results. So I hope you enjoy listening to it. having some delays in moving to the next slide. Great. So I'll follow this outline. So by way of a brief background, Nigeria, like most low and middle income countries, have the same financing challenges when it comes to financing the health sector. Most times we find that predominantly people pay for health through out-of-pocket payments in Nigeria. About 70% of payment for health is through out-of-pocket expenditures, and very low government financing of the health sector. Now, another thing that is important to note is that for key interventions like HIV, AIDS, TB, and malaria, there is a high donor dependency for funding of these key interventions. So in the work that we're doing on the HP Plus project funded by USAID, we actually try to look for ways to stimulate improved domestic financing for HIV AIDS control. Now, one of the key obstacles that must be addressed to have improved allocation and releases of funds for HIV AIDS was actually making sure that adequate resources are appropriated, that they are released, and that they are used on time, which oftentimes was not the case. So we needed to have an understanding of the public financial management, understand the cycle, how things work, as well as understand the obstacles that have been in the way of having an improvement in domestic funding for HIV AIDS. So we used a three-pronged approach. First of all, we did a mapping of the public financial management processes from budget planning to budget execution to budget monitoring, looking at the allocation cycle as well as the release cycle, how the cycle gets started, where it goes to, how it moves from the Ministry of Budgets to the Ministry of Health or the health agencies, how they develop their budgets and then send back to Ministry of Budgets where they have to defend these budgets. And then the budget then moves back to the House of Assembly, that's the Parliament. And then after it's approved at the Parliament, they also have to defend these budgets at the Parliament, and then it goes to the governor for final signing. Now, the budgetary release process also follows the same process, but this time around, it starts from the Ministry of Health or from the health sector agency to develop their budget memos and then send it across to the office of the governor to get it signed, and then to the Ministry of Finance to get the funds released. So having a good understanding of this cycle was very important, as well as understanding the obstacles. So why have we not been having good budgetary allocations and releases for HIV/AIDS before now? Now, another thing that we did was that understanding that allocations and releases to the health sector is beyond the health sector. The people that have the power to ensure that health sector gets adequate releases are outside the health sector, like ministries of finance, the parliament, as well as the office of the governor. We supported the state to set up a multi-sectoral technical working group, bringing in key stakeholders, including civil society, who played a role in advocacy, private sector, office of the governor, ministries of health, ministries of budget, ministries of finance, legislators, as well as NGOs, to actually sit down together and take this evidence that has been generated and applying knowledge of political economy understanding about the people who had influence and the people who had the interest to actually be able to effect a change. We use this to identify the public financial management processes, and then we use this information and evidence to drive change with regards to domestic financing for HIV/AIDS in 2 states, Lagos State and Kano State. Now, we used 3 key strategic approaches, intersectoral collaboration and partnerships. I'm sure before now we know that most times the health sector likes to work in a silo where they would complain about poor allocation to health without speaking to the people outside the health sector who have the power to get more funds to the health sector. So that's needed to change, and we had to work with this multi-sectoral stakeholders to get that to happen. Of course, we made sure we used evidence-based advocacy and stakeholder engagement. So these stakeholders, while engaging them, it wasn't just enough to say, oh, it's about health, it's life and death, it concerns everyone. It was important to show them using evidence why they needed to actually allocate and release more funding to the health sector. And then, of course, we also needed to build the capacity of key health sector individuals on how to effectively engage outside the health sector, to speak in the language that these people outside the health sector would understand. For instance, the finance ministries, rather than saying, that people were dying, women were dying, speak in the language they would understand, for instance, by talking about how improvements in health will lead to economic growth, how it will contribute to employment creation or poverty reduction, for instance. So some of the results that we found on the PFM challenges was that a lot of times there was low budget credibility as well as unrealistic budgets. So most often than not, most states in Nigeria would actually have budgets that are about twice or more of the revenue that they've ever been able to raise at a given time. So what this means is that the best budget execution that it could have is about 50%. And oftentimes the health sector is usually not very well positioned to be able to fight for these scarce resources. Other things we found was that there were often inaccurate costing. So most of the times the costing and the budgeting was not based on evidence. So most times it's rolling over of the previous year's budget and a markup of 10%. And this was not based on any evidence. Budget cycle was often centralized and with a lot of political bias. So if you have a lot of political influence, then you're more likely to get your funds released, of course, because the funds cannot go round. And then we also found within the health sector actors had inadequate understanding of the public financial management processes. They had inadequate understanding of political economy and how they could use this to work to their advantage to get additional funds for the health sector. So the things that we did was that we were able to work with these multi-sectoral stakeholders to have evidence-based strategic engagements where we were able to demonstrate to them the need to have increased allocation to the health sector. For instance, we found that many of these actors from the finance and budget departments felt that donors were funding HIV/AIDS, and so they would rather spend their funds elsewhere. So using evidence, we were able to demonstrate how, despite the fact that HIV/AIDS was being donor funded, there were still huge gaps that needed to be met if Nigeria were to meet its HIV/AIDS control targets. In addition to that, it was important for sustainability for there to be increased domestic resource mobilization. So these things wouldn't have been possible without the multi-sectoral collaboration, the evidence-based engagement. And then of course, we had to strengthen the capacity of the health sector actors to be able to do this on their own. By doing this, we were able to get a lot of results, increased allocation for health and HIV/AIDS in Lagos and Kano states. For Lagos State, over 30% increase in allocation, and Kano State over 26% increase in allocation. It didn't just stop at allocation because we had a three-pronged approach. We're looking at allocation, we're looking at releases, and we're looking at efficient spending. So this also led to releases of this fund. Before now, sometimes even when funds are allocated, it's not a guarantee that it gets released. So we're also able to record results in release of appropriated funds. But even beyond this, we worked with the stakeholders to ensure that these released funds were actually spent on more efficient mechanisms. For instance, they spent more money on purchase of HIV commodities as against traditionally spending money on project management and other things that were seen to be highly effective. So what are some of our conclusions? We actually found that evidence-based engagement, transparency and accountability of health actors are essential in order to overcome public financial management obstacles. Before this multi-sectoral engagement, health sector actors didn't realize that people from ministries of finance and budget thought that they weren't transparent. Some people describe the health sector as a black hole where you put in things and you don't account for how the money is spent. But health sector actors thought that people from finance should understand that this is health and it was important. So through this engagement, health sector actors understood that for them to be able to get additional funding from governments, they have to be more transparent, they have to be more accountable, and they have to execute their previous year's budget for them to be able to get additional funding in the next year's budget. So understanding influence and interest of key actors. So political economy was very important here. Understanding the people that had a role to play, who had the power to draw the funds to health sector, identifying mutual benefits, identifying incentives, and speaking in a language that they would understand was actually the game changer here. And finally, we also found that intersectoral action is the key. So health sector actors most of the time don't have adequate capacity to engage outside their immediate circle. So there is a lot of capacity building that is needed for them to be able to engage these actors that can bring funds to them, grow their capacity on how to develop convincing memos, and make sure that they are constantly speaking to these people, they improve their accountability, and that they are able to maximize the evidence that has been generated from public financial management as well as political economy application to stimulate and influence increase allocation, releases, and spending on the health sector. So I hope you enjoyed this presentation, and thank you so much for listening.
Wonderful. Thank you very much, Francis. That was very interesting, and I'm glad to hear about your experiences in Nigeria. Next, we have our health financing expert on HP Plus in Malawi, Atamandike Chinwanda. Atamandike, can you go next?
Okay, let me just share my screen. Francis, can you please? Thank you. Thanks so much. Okay. I'm trying to move the slides so that we get the first slide first.
There must be some delay. I think the same issue happened with Francis at the beginning. You can try maybe page up or page down, or maybe the arrows, and see if one of those two works.
Yeah, try the page up. Not working. Can I try to share again?
Yep, of course.
Okay.
Yes, now we can see your slides.
Okay. So let me just put it in a slideshow. Okay. Good morning and good afternoon. I'll be presenting on the public financial management in the delivery of healthcare services, the case for Malawi. So this study was conducted as part of the development of the health financing strategy. So we are looking for more evidence on the links between PFM and health financing. So the theoretical links between public financial management systems and the healthcare service delivery have been demonstrated. I think this was done in 2017. Formal demonstration of this. It was done by Cashin and others. So in theory, we expect that public financial management systems will affect health service delivery. However, in practice, there's limited evidence of this, especially in low-income countries such as Malawi. So, based on the possible theoretical links and looking at our context in which the public sector contributes about 23.9% of all funding to the Malawi health sector, and looking at the fact that the public sector also manages about 48% of all total health expenditures and manages 53% of health facilities. We believed that the PFM system must have an important role in health service delivery, but the exact linkage was not formally established. In addition to the management of 53% of health facilities, the government of Malawi also contracts the Christian Health Association of Malawi, which manages 20% of all health facilities to provide the selected healthcare services free of charge at the point of delivery. It also provides salaries to CHAM facilities. And most recently, it has also started it has contracted the Islamic Health Association of Malawi to provide further selected health services. So you can see that potentially public finances and their management are very critical in improving healthcare services and outcomes. So this is why we set out to conduct a study so that we can have the formal links. So the methods that we used, we borrowed the WHO assertions or a theory on the possible linkages between the public financial management system and the healthcare financing functions, focusing on the three financing functions for raising revenue, pooling, and purchasing. And you can see that on your left in the picture, the PFM system can be summarized to mostly three functions: budget formulation, execution of the budgets, and then monitoring of the budgets. And then for both the health financing functions and the PFM systems, we would like to see service delivery that is effective, efficient, equitable, of high quality, but also that is accountable. So using this framework, we designed questionnaires for a rapid assessment, and we collected the data at the national and the subnational levels. The sampling method was purposive in nature because we wanted to target stakeholders that are really involved in the PFM systems. And for data analysis, we used the thematic content analysis, and then the findings were validated by several groups. The one that is tasked to develop the health financing strategy, but we also validated the findings with the multisectoral commission, the multisectoral committee on the sustainable health financing, which comprises Minister of Health, Minister of Finance, and Ministry of Local Government. Of course, now also we also had the discussions with the Clinton Health Access Initiative. So those are the 4 major players in the Multisectoral Committee on Sustainable Health Financing, which validated the findings. I'll briefly present on the results because just on selected key issues. The first one being on the budget classification. So since 2014-15, the Malawi government has been using program-based budgeting, so that the focus is on the outputs that we want to achieve. So in theory and on paper, the way the budget is classified is the PBB, and it is designed as such on paper. However, in practice, the change hasn't really been affected so much, so that it's still akin to the old ways of budgeting. So really, the PBB has not had any impact in accountability for results, and also not much change in efficiency and effectiveness, because the results chain from the budgeted amounts to the outputs is unclear, and the targets are unrealistically high. So in short, the PBB is just implemented on paper. There hasn't really been efforts to bring it to fruition, at least in health. So how are the resources allocated? For interministerial resource allocation, there's there's no formula, so it's mostly based on historical trends, and this also applies to intra-district resource allocation. However, for inter-district resource allocation, a new formula has been developed that also considers the equity and the epidemiological conditions. So this formula has not been rolled out yet. We expect it to be rolled out in the next financial year, that's 2022-2023. And also, again, resources are not enough to meet policy goals. So on the resource allocation, the impact on services is that there hasn't been much focus on using the PFM systems to achieve equity. And also, there hasn't been much focus on using the public budget to improve effectiveness. So, like the resources are allocated just for inputs. And then on the provider autonomy, really there also hasn't been much change on this. There isn't so much autonomy for providers, and this is worse for lower level, primary level providers. And the impact of this is that there's shortage of vital supplies for service delivery. Provider payments, I think we still use capitation to provide for to make provider payments. So this leads to little incentives for efficiency. And on the budget monitoring and accountability, like I had already alluded, indicators are developed, but then there's no clear linkage between what is budgeted for and the results that you want to achieve using the budget. So there's a very limited accountability for results. So a few questions for discussion from colleagues. When it comes to those that have implemented program-based budgeting, because one of the reasons that was said for not adopting PBB was that the funds are not really sufficient, so that they're just put to fund the basic routine work. So is there a minimum amount of funding that enables implementation of PBBs? And what are the key environmental activities that are necessary for successful implementation of PBBs, especially in health? So just to conclude, the study had said that had recommended that we need the better political economy analysis before implementation of PFM, and then we also need to engage more engagement with key service delivery ministries in the implementation of PFM. So on PEAs, I hope to learn more from the Nigeria situation. So thanks so much for your attention.
Great. Thank you very much, Atamandike, for your interesting results in Malawi. Next, I would like to pass the microphone on to David Kaoya, Deputy Country Director for HP Plus Kenya. He'll talk about shifting on the PFM paradigm and the effect that those had on counties in Kenya achieving important budgetary gains for health. Francis? Sorry, David.
Thank you very much. Let me share my screen. Okay.
Yep, we can see it.
Thank you. So thank you very much. And if you allow me, I want to present without a video so that I can put it after to allow my slides to move faster. So my name is David, as you've been told, and thanks for the other presenters. I'm presenting on the reforms that we've witnessed in the public financial management across the globe and contexting them to the Kenyan case. And basically, I'm looking at some of the budgetary gains that we have gained as a result of some of these reforms. So as a way of background, Kenya promulgated a new constitution in 2010, and this constitution was supposed to be effected from 2013, which introduced a devolved system of government. But in between, before the implementation of the constitution, the country developed the PFM Act, which provided guidelines and also required counties, and the counties at the subnational level, to actually use the program-based budgeting format in their budgeting. But by the year 2015, most counties at the subnational level were struggling with the implementation of a program-based budgeting system. So it was at that time that in 2015, the USAID requested Health Policy Plus in collaboration with the Kenya School of Government to actually intervene and support counties to be able to undertake or implement the program-based budgeting. And what we did as Health Policy Plus was to collaborate with the Kenya School of Government to develop manuals and a template for the county health management teams to be able to use to prepare the program-based budgets during their budgeting process. Health Policy Plus also assisted the focus counties to build evidence by tracking resource allocation and expenditure and tracking health financing indicators to determine their impact on health outcomes. The other strategy we took was that we gave the county health management teams tools and guidance on how to influence the budget approval process, basically advocacy skills for their needs, and identify ways they could improve efficiency in resource allocation and utilization. This, of course, we did through the evidence we supported them to generate and also use in terms of how they were allocating their resources, and also assisted them to participate in the procurement processes, as opposed instead of leaving other departments to procure for them. The other issue is that allocation and expenditure data were also used to track and analyze county health expenditure trends And what I want to mention here is that our focus was in a few selected counties, and these counties were selected by our donor, the USAID, and for our intervention. So as a result of these interventions, there was overall increase in just about 2 years. 9 counties where we were working we provided intensive support collectively increased their health budgets to 27.2%, and this was contrasted with the national average that only rose marginally to about 25%. That was our first indication that our intervention was actually working or had worked. The additional money, because we also followed to look at where they are actually using the money as the funds were increased. So the additional money allocated in the targeted counties was utilized to purchase medicines and other medical supplies, ensuring that people get the care they need without any financial risk, increasing access and reducing catastrophic expenditure. As you know, most of the cost drivers for our out-of-pocket spending was basically on medicine. So by buying medicine, I think the out-of-pocket spending automatically went down. The chart you see on the right is just showing the proportion of total county government budget allocation to health. And you can see the contrast between the counties where we focused, which we called the deep dive counties, how they increased their allocation, contrasted with the national average, or the other counties where we did not do extensive intervention. So and just to focus on 2 counties where we worked very hard, Nyeri and Mombasa. Nyeri County used to spend a significant portion of its health budget on staff salaries. However, following our intervention, the county health management team planned for the retirement and replacement of 280 staff and hired new staff on fixed-term contracts, saving over $60,000 per year. The reason why this was important is because most employees in the public service are normally employed on permanent and pensionable basis, and it becomes very expensive whether because they are paid whether there is a workload or not. So by contracting, they were able to actually only contract staff that were needed. Nyeri County also increased its health budget by more than 20% just over that period that we intervened. In the case of Mombasa, the Mombasa County Health Management Team increased the budget allocation from 12% of the total county budget in 2015 to 27%, almost more than double in just two and a half years. At the same time, their out-of-pocket spending in that county drastically decreased from 41% to 34% in just a period of 2 years. And as I've said, it was just because of the fact that the county was able to provide the essential medicines that people require. So in conclusion, implementing PFM reforms and building PFM capacity are very highly context specific. In the case of Kenya, strengthening existing institutions ensures that reforms are locally defined, long-lasting and well-coordinated and aligned with fiscal, administrative, and human resource realities on the ground, as we have seen in the case of Nyeri and Mombasa. So developing systems and local capacity in evidence generation and use is key in defining needs, because needs, as you know, inform norms. And the needs in these 2 counties actually required that we be able to work on their PFM reforms so that whatever they do now is aligned to the reforms that we have actually supported them to implement. In addition to linking inputs with outcomes, putting the program-based budgets into practice at the local level, especially in the counties, and building the required institutional capacity has provided counties with a broader view needed to identify and resolve bottlenecks and make adjustments and influence budgetary decisions. All this we have achieved because of the support we've received from the USAID and through the collaborations we have had with other stakeholders in the health sector. Thank you very much for listening to me. Over.
Wonderful. Thank you very much, David, for your presentation on those interesting results at the county level in Kenya. We have approximately 10 minutes for some Q&A. I have been able to track between 4 to 5 questions. Let me start by sending a couple of questions to Francis on the case of Nigeria. Our colleague Pallavi Sharma asked, Francis, if you could talk a little bit more about the process that you undertook to help build the capacity of others to advocate with the MOF, with the Ministry of Finance, and also our own Atamandike. He wants to know that when you say that you use evidence to persuade stakeholders to increase funding towards HIV, what pieces of evidence were you able to use, and how specifically were they targeting stakeholders? If you can work with this on these two questions, then I have a couple for Atamandik and David. Francis?
Thank you very much, Jorge, for the excellent questions. So with regards to the process that we used to build the capacity of key stakeholders, so we concentrated on building the capacity of HIV actors at the different HIV agencies, including SACA, NACA, and the HIV agency within the Ministry of Health. And we also built the capacity of the technical working group, which included CSOs, to advocate for additional allocations to the health sector, and also build the capacity of people from other ministries on the issues with the health sector. So it was a multi-sectoral capacity building, but a lot focused on the health sector, HIV actors that needed to actually develop these memos. Now, the processes that we went through included structured trainings and capacity building sessions to improve their capacity on how to write convincing memos and how to start the budget process on time, how to use evidence, how to track budgets, use evidence from budget tracking to develop annual operational plans, which they used to develop a budget, and how to start this process early enough so that they will have a budget that is informed by evidence ready before the budget cycle starts, so that way they're able to send in a good budget, be able to defend it at the two different ministries, but also be able to ask for their funds on time and support it with evidence to get this funds released. In addition to the structured trainings, we also did a lot of on-the-job capacity building. So we worked with them, they watched the way that we try to bring this other people from other sectors together. Many of them were saying, oh, we didn't know it was this possible, for me to just call a parliament and talk about an issue on health. Well, because of this multi-sectoral technical working group, they were able to do this thing. So the capacity building cut across technical capacity building of the key HIV actors, organizational capacity building for them to routinely track budgets, routinely develop annual operational plans that will build into the budget process, training the actors or the people who are responsible for writing these budgets, how to write convincing memos, how to make sure they send them out on time, but also went to relational capacity building. So building their capacity to be able to engage outside the health sector, including the finance sector, being able to speak in the language they would understand. For instance, I had mentioned when you're speaking to people from finance sector, don't only say that women are dying, children are dying. You have to talk about how the funds that you're requesting contributes to the broad agenda of the government, of the state, for instance, in poverty reduction, in employment creation. How will this make sure that more people have jobs and things like that? So it was actually a very holistic approach that cut across different sectors, and it was multi-sectoral in nature. Now, the second question that was talking about what evidence was used, a lot of evidence was used to actually engage some of these key stakeholders. Some of the ones that we found the most convincing were evidence from budget tracking and evidence from health financing landscape that actually showed that despite the fact that HIV/AIDS was being funded by donors, that there were still huge gaps that needed to be funded. There were key program areas that were not getting adequate funding. And that if we're to meet the 95, 95, 95 targets, or to conduct all the interventions in the HIV strategic plan, we needed to close those gaps. before then, people from many, I think perhaps the biggest hurdle to scale is that belief that HIV/AIDS is a donor domain, that it's well taken care of by donors. So oftentimes people would engage the stakeholders without evidence. So we're able to put it on paper to show them this is what is being spent, this is what donors are spending, these are the gaps, and this is what will happen, if enough is not done in these areas to actually address HIV/AIDS control. And I think another thing that we also found very useful was also showing them evidence about gradual declining donor funding to make them understand that donor funding is not sustainable and that it could go away at any time. So if we're talking about sustainability of these control measures, then we have to talk about domestic resource mobilization. So I'd like to stop here.
Great. Thanks, Francis. A couple of questions for David. David, it's our colleague Stephanie. She's saying, the interesting results from Kenya. She's wondering if the budget increase that you showed on the deep dive counties compared to the control counties, if the difference was found to be statistically significant. That's first, and second. Sally Lake is asking if it's possible to say a bit more about how Haneri County managed to retire surplus staff. She's wondering if counties have complete responsibilities for hiring and firing. Was everyone of pensionable age? How did that link with the National Public Services pension schemes? Since apparently that seems to be a challenge for the both levels. David?
Yeah, so thank you very much. And I think she's right. We did a lot of tests to ensure that the difference that we observed was statistically significant. And I think due to the interest of time, we tried to summarize our results for this purpose. But we are able to provide more information to show that that type of difference and show that it was significant. With regard to Nyeri County, the way they did take care of their surplus staff is basically, every year they had staff who are retiring, and what they did is that instead of replacing with permanent and pensionable staff, they now replace them with contracted staff. So it's not like they asked staff to go, but they were replacing those who are due to go with contracted staff. And for the purpose of the audience, in Kenya, the health is fully devolved, where the counties at subnational level are fully responsible for hiring their staff. The only function that is left to the central government level is training, but even that is actually in collaboration with the counties. So through that, they were able to replace staff, especially those who are retiring or with who had reached the due age with contracted staff. And by all fairness, the contracted staff are cheaper compared to permanent and pensionable employees. Over to you.
Great, thanks, David. A question for Atamandike. Somebody asked about the role that audits can have on PFM. What's the effects that audits are having, if any, specifically on budget accountability and performance? Atamandike.
Okay. Thank you so much, person. I think audits are a very important component of the PFM system. With the audits, the structures that currently you can have both internal and the external audits, and the audits can focus on both the inputs and also finances, but currently they are not focusing on programmatic outputs. So in terms of the impact that has been noted, I'll give one positive and one negative. On the positive impact, I think the in 2016, there was USAID had uncovered the misuse of medicines, especially anti-malarials. So when this was brought up to the attention of stakeholders, including the MOH senior management and the health donors, I think there was initially there was a plan to stop donations of medicines, especially anti-malarials, and now for anti-malarials, I think the major source is through donations. However, the response of the government was to initiate, first of all, before all the suspensions, to initiate frequent and regular audits of the medicines. So the result was that right now misuse of medicines is or drug or leakages has gone down by about 60% or so. So in that case, I think audits have had a very important role. So in strengthening the accountability of public resources, or resources that are now that are being managed in the public sector. On the negative side, I think, or is it positive side for the in case of audit advocacy? For this last year, when we had the COVID-19, when it just started, in around March, April in Malawi. So the government had sent out some funds to districts in response to the COVID-19 pandemic. So when so the funds, as they were deemed to be in an emergency, it was done without much due diligence. So when the funds were sent to the districts, I think there wasn't proper accountability. So the next tranche, the auditing team was used to provide risk management advice and how it should be managed. So since then, the accountability and use of COVID-19 funds has greatly improved. So the audit function is a critical but usually ignored function of the PFM system in Malawi. Thank you.
All right. Thanks, Atamandike. I'm sure that there are a lot of follow-up questions that we wanted to do to that particular response on the role of audits. In the interest of time, it's already, well, at least here in DC, it's 8:31, and I'm assuming that some folks may want to join some of the other sessions on IHEA. So I think that this may be a good moment to stop. I want to end the session by thanking our four presenters, Sunita, Francis, David, and Atamandike for the presentations. I also want to remind all the participants that should be able to access the full presentations now and later, as explained at the beginning. So again, I thank all the presenters for your interesting presentations, for this discussion, and you can also use the platform if you want to connect directly with them, and hopefully we can stay closely engaged on PFM issues in the future. So thank you very much, everybody, and hopefully we'll be in touch.